Welcome to Beyond the Thyroid. This is Dr. Dana Gibbs, and we have a guest today. This is somebody I deeply admire, Dr. Celine Lee. She goes by Celine. She's a board-certified rheumatologist and the founder of Lotus Rheumatology and Wellness Clinic in Salt Lake City, Utah. So Dr. Lee really has a totally unique background because she began her career as a dermatologist in the country of South Korea, where she quickly noticed that many skin conditions were actually signs of deeper autoimmune diseases. And that insight led her to immigrate to the US, where she had to start over and do an internal medicine residency and then a fellowship in rheumatology. So she is now board certified in internal medicine, rheumatology, and lifestyle medicine, 3 board certifications. Wow. So she has over 20 years experience in the medical field and has developed a really rare ability to connect the dots between symptoms and underlying root causes. And her practice is grounded in whole person care, using essential medications while empowering patients to change lifestyle to activate their body's natural healing potential. So today we are going to dive into autoimmune disease and the fascinating overlap between the rheumatologic autoimmune diseases and the hormone-related autoimmune diseases like Hashimoto's and type 1 diabetes and other chronic inflammatory conditions. So if you've ever felt like your symptoms were dismissed or they didn't really fit neatly into a box, this episode is for you. So let's get started. You're listening to the Beyond the Thyroid podcast. I'm your host, Dr. Dana Gibbs. I'm an ENT surgeon and hormone specialist. For years, I struggled with my own unrecognized thyroid problems before and even after I was regularly performing thyroid surgeries. Then, one day, I learned something that turned my health around and opened my eyes to the limits of mainstream medicine in treating more subtle thyroid abnormalities. I spent the next 20 years fine-tuning my hormone expertise in disorders like Hashimoto's disease, perimenopause, and stress-related illness. Come join me as I share this new approach to hormones that empowers you to take control of your own thyroid and hormone imbalances. Let's dive in. Hi, everybody. Welcome to Beyond the Thyroid podcast. Today, I have a special guest with me today. This is my friend, Dr. Celine Lee. And Dr. Lee is a rheumatologist in direct care practice in Salt Lake City, Utah. And we are going to have such a fun time because we are going to talk about the overlap between rheumatologic and hormonal-based diseases like Hashimoto's disease. So welcome, Dr. Lee. It's so good to have you here. Why don't we start with what rheumatologists do and what is a rheumatologist? Because I'm not sure that everybody even knows what kind of diseases you treat and what a rheumatologist is.
Yes, the rheumatology is a kind of weird long name that most people usually don't even know that exists until they develop some type of symptoms that will require rheumatologic evaluation. I have many patients told me that they never heard the terminology rheumatology until they develop these symptoms. So rheumatology is a specialty that diagnose and treat systemic autoimmune disorders such as rheumatoid arthritis or lupus or Sjogren's syndrome, scleroderma, dermatomyositis, and those diseases are the immune dysregulation disorders that where their own immune cells attack the healthy tissues of the person that can cause inflammation. As you know, there are many autoimmune disorders to the thyroid. S is more to the CNS. Type 1 diabetes is more the pancreatic beta islet cells. But in rheumatology, we usually treat the disease that is more multi-organ disease, like a systemic disorder. For example, lupus can go to almost any organs in the body, so we treat those diseases particularly.
Okay, that's a great way of putting it because I was going to ask you about that since type 1 diabetes seems to be the purview mostly of an endocrinologist, but then they don't really have experience in multi organ system autoimmune disease. The same goes with Hashimoto's disease. And so I'm sure, I think the reason you and I got to really know each other is because so many people get diagnosed with the antibodies for Hashimoto's disease and end up in your clinic with a, oh my gosh, I have a rheumatologic, or, I have an autoimmune disease. What kind of doctor treats an autoimmune disease? And they end up in your office because of that.
That's right. There's a lot of overlap.
Yeah, there's a lot of overlap, but it seems like some of those diseases are kind of orphan diseases. You mentioned already some of what kind of the diseases you treat. So tell me in particular, how did you get interested in rheumatology and how did you decide to open a direct care rheumatology practice? Because I know there's a big story there.
Yeah. So I started actually as a dermatologist. So I was trained in dermatology, and I'm actually a board certified dermatologist back in South Korea. And I was mostly interested in rheumatic skin disorders such as lupus rash, psoriasis, dermatomyositis rashes, sarcoidosis. So those are the skin disorders that really excited me in treating and discovering what's more in the person's immune system, because often those skin rashes are just the tip of the iceberg that signals there's something going on inside of the body. So whenever we see those rashes, I was always thinking about what's causing this rash, what's happening in the body that caused this rash, and that always like leading to the deeper like investigation. And often those rashes were from autoimmune disorders. A lot of lupus patients and even psoriasis patient as well. So that's kind of how I started it, my interest in autoimmunity. And when I moved to United States, I was thinking, because I have so much interest in the rheumatic skin disorders, and I was kind of wanted to do more because as a dermatologist, we really cannot treat the systemic, those symptoms. So for example, I cannot treat lupus nephritis when I'm a dermatologist. And I was kind of thinking, why can't I just treat that too? So so that's the reason why I changed my specialty to rheumatology.
I see. And did you have to do more specialty training when you came to the US? They would not accept your Korean specialty training, would they?
Oh, yes, I had to do another. So I have 11 years of postgraduate medical training. So I did 6 years in South Korea, so 2 years of transitional years, 4 years in dermatology residency. And then after coming from to United States, I had to do another internal medicine residency for 3 years, and then 2 years of rheumatology fellowship. So 11 years.
Oh my goodness. I don't guess I realized that they made you do internal medicine over again. So you're probably one of the most hyper educated people I know. Oh my goodness. Okay. And how did you decide that direct care practice was what you wanted to do?
So I always have this feeling, a little bit of like you could almost say like guilt when I was working in the more traditional setting of medicine, because as you know, in the traditional medicine in the US healthcare, the time is always, lacking. So when the person have autoimmune disorder, usually it's a multi-system disease. So we need to ask a lot of like almost all organ system. We need to evaluate if the person have, any CNS symptoms, skin symptoms, pulmonology, cardiology, nephrology. So we need to ask a lot of question and do the evaluation. But in traditional system, time was really restricting factor. I could not spend sufficient time with the patient and always felt like I'm not doing enough for the patient because there's so much things that I need to evaluate, so much things that I need to talk to the patient and counseling of a lifestyle modification, how the diet can impact their autoimmune disorders, all of those things. But when you see like 20 patients per day, it's really difficult to do that, and I felt that I can do more outside of the traditional system. So that's the reason why I changed to direct care, and I think that was the right decision.
Oh, I'm right there with you. And it's funny what you're saying about that, because making me think about another person that we both know that I heard talk earlier this week, and she said, you know, there are diseases that no specialty claims, because they're like, oh, I have to stay in my lane. I have to just do these multi-system rheumatologic diseases. I have to do just gynecology. I have to do, and she's a urologist. So she was like, well, I'm teaching hormone treatments to the hormone doctors. And I was like, oh my goodness, mind blown, because there is overlap. There's overlap, and it's amazing how many different conditions, particularly in women's health, are just kind of like, nobody treats that. Sorry, go away. You know, and Hashimoto's is kind of one of those. So tell me how you got interested in treating Hashimoto's disease.
Oh, yes. So Hashimoto disease is, so we in rheumatology fellowship, we actually don't learn about Hashimoto disease. We just learn that there's some positive ANA in Hashimoto disease, and that's about it. We don't get trained about how to treat Hashimoto disease, about the hormonal replacement therapy, things like that. We just hear about it, and that's it. But real life, after I became attending, I see these patients with positive TPM antibody quite high titer have symptoms and fatigue and joint achiness and stiffness, but without rheumatoid disorder evidence. And when I refer, a lot of patients were told that, oh, their TSH is normal. So, just like observation was the only thing that they were able to get advice. And I thought that maybe there's a little bit more story. And because I see these patients and they come to me asking for answers, and because there's a shortage of endocrinologists too, and I was thinking, why can I just learn about a little bit more of Hashimoto disease? Because this is a disease that it's an autoimmunity, and autoimmunity is, I think, it's a part of rheumatology.
I think probably there isn't anybody who knows more about autoimmune disease than rheumatologists. So, yeah, that makes total sense to me. And, you know, coming from the world of ENT, I had the same thing. People would come in, they've got these lumps in their neck. I do a biopsy, it comes out chronic lymphocytic thyroiditis. And you know, it's funny. I'm thinking back to when I was first an attending, and I got that diagnosis, you know, the second or third time I got chronic lymphocytic thyroiditis. I was like, oh, well, these are not cancers. And what is this chronic lymphocytic thyroiditis? And I looked it up, and it was like, oh, this is Hashimoto's disease. What the heck? And then I was like, okay. And I didn't even realize at that time, I mean, and this is 25 years ago, of course, I didn't even know there was a test for Hashimoto's disease. I didn't even know. That's how bad, you know, here I am taking out people's thyroid glands left and right, and I didn't even know there was a test for Hashimoto's disease when I first started out. It's very frustrating to me for people to come in and be like, oh, well, my endocrinologist said that I don't need any treatment, or my endocrinologist said, here, take this levothyroxine, but I don't feel any better. So yeah, absolutely. The getting out of your lane thing is, I don't know, I think it's part of the direct care movement a little bit. It's like, let's look at the whole person and treat the whole person a lot more than the specialties who are, you know what, I got enough work to deal with in what I know to do. I'm not going to focus on anything that I don't know to do.
Yeah, and I think that it is important for us to recognize that even though there's a lot of advances in medicine, we still don't know a lot of things about human body. And I think this subspecialization kind of almost make us forget that all our body organ is connected, and also our mind is connected to our body. And as you know, in the hormones, how the stress can impact the hormonal system, and our hormonal system can cause joint, and the muscles. They're all connected.
Joint and muscle pain. That's another thing that I was that interview with Rachel the other day, and she was like, you know, I'm a urologist. What am I doing treating all this joint pain? And I was thinking was thinking the same about myself, since I've started into There's so much overlap between the thyroid patients and the perimenopause. And you're right. I mean, it's just like you can't just stay doing one thing. You have to be curious about the rest of medicine. And if we're not, then the research is not going to get done. The body of knowledge is not going to expand, and we will keep failing our patients as far as that goes. So that brings up another question that I had, which is something you mentioned right at the beginning, and that is, how do you see this connection between Hashimoto's disease and the elevated ANA test, anti-nuclear antibody test?
Yeah, so ANA antibody is basically an anti-nuclear antibody. So it is an antibody that binds to the nucleus. So usually we test it by we put the patient's plasma to this little slide that is coated with the HEP2 cells. So those are human epithelial cells. That is just kind of, it's actually you probably know it's actually stem from laryngeal carcinoma patients. And that happened to be just kind of very large and very flat cells. So it's very easy to use for this test. And we basically coat a slide with those cells and put the patient plasma there and see kind of culture it so that if there's any anti-nuclear antibody, it'll bind to the nucleus. And then we put up the secondary antibody, they have a fluorescent like little tag and to see, if we see those antibodies attached to the nucleus. So that's the anti-nuclear antibody. And basically, it means that the person's immune system produce this antibody that attached to human nucleus. So that's the reason why this can be a signal that this person could have autoimmunity. Having positive ANA does not necessarily mean that the person have autoimmune disorder because there are normal people who have positive ANA without any rheumatic disorders. So one of the most common consult that rheumatologists get is a positive ANA consult, and people who have positive ANA have to be evaluated for potential rheumatic disorder. But just because somebody have positive ANA does not mean that the person have 100% rheumatic disorder. So I always kind of tell patients, don't panic about their positivity. It's a blood test result because as long as you don't develop the disorder itself, having the antibodies, themselves alone does not mean that you have a disorder. And in fact, the positive ANA increase over time. So people who are older than 65 years old, about one third of people can have positive ANA without having any disease. Yeah, it's quite high actually. So that's the reason why it's very important to differentiate whether or not the person have rheumatic disorder or just have a positive ANA without any disorder, because the implication is quite significant because rheumatic disorder usually requires treatment that suppress the immune system. And obviously, we don't want to suppress the immune system for everybody who have positive ANA. That'd be, yeah, one third of the population older than 65 years old. Yeah, that's the reason why the evaluation is important.
At the beginning of the discussion, we talked about these three diseases that are not really considered rheumatologic diseases, but they are autoimmune diseases. And we mentioned type 1 diabetes, which attacks the pancreas. We talked about MS, which attacked the immune system. And then we mentioned Hashimoto's disease. How often, if you get somebody in to do a consult for a positive ANA, do you test them for all three of those disorders to see if they have those antibodies? How do you think about that person when they come to you?
So the most important thing is actually the patient symptom, because in rheumatology disorder is autoimmune inflammatory disorders. So the inflammation will cause the symptoms. So whether or not the person have the rashes, especially photosensitive rash, that is common in lupus or dermatomyositis, or joint pain, joint swelling, morning stiffness, inflammatory back pain, those kind of symptoms, or whether or not the person have abnormal blood tests such as increased liver enzymes, increased creatinine, which can signal the declining kidney function, protein in the urine, chest pain, shortness of breath. history of multiple miscarriages, which can be seen in antiphospholipid antibody syndrome.
I'm sorry, say that one again. In what kind of syndrome?
Antiphospholipid antibody syndrome, which can cause multiple miscarriages and blood clots, such as DVT or pulmonary embolism. Then that is also autoimmune disorder. So I think the most important thing in evaluation of these patients who have positive ANA is actually clinical history. And the clinical history taking should be really thorough to look for any clues that could give out that this person have rheumatoid disorder. That's the reason why the time is important to really dig into all the history, like what happened like 10 years ago. Yeah, those kind of things. And all these like chronological events, because sometimes this symptom will, wax and wane, it comes and go, and sometimes it'll build up. So eliciting those history is the most important thing. And then physical exam to see if there's any rashes hiding somewhere or the joint swelling, synovitis, enthesitis, if the person have any breathing problem, crackles and things like that. And then blood test. The blood test, so positive ANA does not necessarily have a positive ENA profile. So ENA is extractable nuclear antigens. So those will be, the Sjogren syndrome, like a SSA, SSB, RMP, JO1, those kind of antibodies. So if somebody have those ENA profiles are also positive, they are more likely to have actual rheumatoid disorder. So yeah, whenever I have a positive ANA patient, I usually check those antibodies to see if that person have any other more specific antibodies that signals to a rheumatoid disorder. And history in the physical exam very important.
So, do you test them then for the anti TPO antibody? And you do as a routine now?
Yeah, absolutely. Yeah, it's in routine, anti-TPO and anti-TG. Yeah, I always check that because those people can have Hashimoto disease. And it is known that the Hashimoto disease patient have about 35 to 45% will have ANA antibody, and about 15% of them will have a rheumatic disorder in the future. So it is important to check those antibodies.
You mentioned this before. You were saying about that the immune suppressant medicines are important, but when you're treating rheumatologic disease, there are other ways that we use to help people calm down. You said it's an inflammatory condition. It's like, okay, what are we going to do to calm down this inflammation? So, what kind of things do you advise your patients to do that helps them control their inflammation besides just taking a medicine?
Yes, so I usually tell my patient, so the body is already inflamed, meaning that the body's immune system thinking there's some enemy, and it is kind of dysfunctionally too much of activities to the point that it's actually attacking your own tissues. So it is not necessarily low immune problem, it's the immune dysfunction problem. So when immune system is already too sensitive and too irritable to the point that it's attacking the person's own tissue, if you give external triggers that will fuel into the inflammation, it'll just make it worse. It's so obvious. Yeah, and there's a very universal trigger for inflammation that we actually voluntarily put in our mouth. And those are inflammatory food. Sugar is universally inflammatory. Yeah, and I don't think sugar is actually a food because it's actually, yeah, it's when you think about there's no plants that have sugar, powdery sugar as a, yeah, it's actually extracted by the cane sugar by chemical extraction. And it is very well known that sugar can cause like trigger symptom of RA patient and lupus patient. In fact, that Christmas time is one of the seasons that I get a lot of phone call for the RA or lupus flare because we tend to eat a lot of cookies and cakes, and they can often trigger inflammation. And not sleeping well.
That's something that never would have occurred to me. That's so interesting. But you're absolutely right. I mean, there's candy everywhere and everybody's eating cake and cookies and pie and oh my gosh, yeah.
I mean, it's okay to eat, but everything's moderation. Maybe one cookie is fine, but if half of the cookie jar is empty by the time they, maybe that's not okay.
Well, I mean, you go to a Christmas party and it's like, oh, but there's 27 kinds of cookies. I got to try them all. Wow. What other inflammatory foods do you particularly see as problematic for people?
But the processed food, so processed food that anything that it's pre-made and you just heat it up in the microwave, majority of those food have preservative, and those are chemicals. And when it goes to our body, our immune system, evolutionally, our immune system are not supposed to see those chemical preservative because it doesn't exist in nature. So when you think about the really popular diet like paleo diet, and we just go back to time, we just eat whatever that was available in nature. Whole grain, not processed fish or some games, those kind of things, and none of them had chemical preservative in it. But right now, in our era, and if you put some like the junk food or fast food in, just kind of let it sit in the room temperature and see how long they last quite a long time. And when you put like,
I'm thinking about Twinkies, but
yes, and Twinkies, yeah, they have a lot of sugar in it and they just like last forever. So it's not natural.
it's completely unnatural.
Exactly, that's unnatural. So they might be good for emergency situations. If we have disaster happened and we have to just live on something, maybe that's helpful for that. Just give us a calorie. But they are really not natural food. And the non-natural things in those food, when it comes to our body, it really confuses our immune system because it's not something that our DNA is trained to recognize as beneficial for our body because it didn't exist. Just about, just like a few, just like 100 years ago, you know, it didn't exist, right?
It didn't exist.
Yeah, uh-huh, exactly. So our body does not know what to do with it. And whatever things that our immune system doesn't recognize becomes the target of attack. So any food that have a chemical preservative can cause inflammation in our body. So I usually tell my patients try to avoid sugary food and processed food. And even those two things can cause a huge impact because a lot of food that we can just buy from grocery store, if we are not careful about those ingredients, we'll buy a lot of sugary processed food, like Twinkies.
Yes. I mean, fresh vegetables, fresh fruits, beans that you cook yourself, even if they're dried, they're still pretty good because there's not a lot of preservative there. I think you're right, absolutely, about that. Anything else? I mean, food obviously is super, super important, but what about other techniques? Do you encourage people to do yoga or acupuncture or any other modalities that you find to be really helpful for rheumatologic disease?
Yes, actually, the thing that I've stressed after the diet is sleep. So sleep is so important that there's like bad names about sleep, saying that, oh, sleeping is just you're not doing anything, you're not productive. But sleep is actually probably the most productive time for our body system. Our conscious mind is resting, but our physiology is probably the most active during our sleep. So if we are accumulating this stress and inflammation in our bodies and the tissues get these inflammatory molecules, if we can get enough sleep and enough nutrition, our body can heal a lot of things without taking any medication. And so for adult, about 7 to 8 hours of sleep, and that is really essential. It's so essential to the point that in the war they use sleep deprivation as a tool of torture.
Yeah, you're absolutely right. They do. In medical school, too.
Okay, that's right. Yeah, we are kind of partially tortured in medical school and residency. Yeah, and these soldiers, strong minded, strong body soldiers, they break, with just deprivation without any pain method. And because our body cannot survive without getting enough sleep. And unfortunately, these days, because of too much screen time, there are so many interesting in the social media, all the reels and shorts and TV shows, and a lot of people lose sleep, and it's kind of they're torturing themselves. So anybody who's getting less than 7 hours of sleep, we can almost guarantee that there will be some unresolved inflammation in the body. They will be just carry on to the next day. Um,
It's funny. We call that a doom loop in my house. It's like when you get sucked in and you can't get away because they keep showing you more and more and more things that you want to watch. It's like you can't get away. You're in a doom loop. Yeah. All right. So we've got watch your inflammatory foods. We've got sleep as a key. Anything else that you particularly encourage folks to do that's not a medication?
Yes, so in rheumatology, as you know, that joints are one of the most common target of autoimmunity. So rheumatology is actually not a joint disease. It's an immune disease, and joints just to be the kind of everybody's doormat. Just a kind of easy target that any autoimmune disorder actually can cause inflammatory arthritis is because they're right there to attack. So whenever this immune inflammatory cells see the synovium or tenosynovium, they just like to attack them. So inevitably, a lot of patients will have joint pain, joint stiffness, and associated muscle pain. And sometimes people just don't want to move because of this, which is very understandable. So when the joint is inflamed, it's painful to even just move. So patients tend to not move, which can cause other problems too. So yeah, when the patient starts the treatment, the inflammation will go down. And as soon as the inflammation is going down and the joint is now safe to move, I usually ask the patient to start some light exercise. It is important to note that when the joint is severely inflamed, they actually should not exercise because severely inflamed joint, if they are getting additional physical strain, it can actually get worse. And worst case scenario, for example, if somebody have psoriatic arthritis and have Achilles tendonitis, and if somebody try to exercise and strain that inflamed Achilles tendon, it can rupture. So these actively inflamed joints and tendon need to be rested. However, once that inflammation goes down, then the patient should start some light exercise to preserve the range of motion of the joint and thus to prevent contractures of the joint. And this is very important. And if the patient fears that, oh, my joints are inflamed, I should not move, and just got stuck in that state too long, then the person can be deconditioned and their joints can lose range of motion, the muscle can atrophy, and the person's physical health can decline overall, and they can develop physical deconditioning. So I usually tell my patient once the active inflammation goes down, make sure that they do some exercise.
That's super interesting. So if I see a patient with Hashimoto's disease, and because that's mostly what I see, and they have joint discomfort, how do I advise them on whether they should have an ANA test or a rheumatologic workup? What history elements am I looking for?
Yes. So as you know, the thyroid disease and, and the menopause and those deficiencies, yeah,
Perimenopause and menopause. They all cause joint pain.
exactly. They all cause joint pain and joint stiffness, and you all feel achy in the morning when you wake up. So it's very similar, and that's one of the reasons why it's so confusing. And we have a lot of overlap because the Hashimoto disease, hypothyroidism, menopause, rheumatoid disorder, they all cause joint pain. But there's some key differential that kind of give you some signal that this could be more than thyroid or estrogen deficiency. When we see the morning stiffness lasts for too long, so it is normal af after we get older, and I'm feeling it these days too because I am perimenopausal myself. We feel a little bit of stiffness. I'm in my 40s, so I'm getting there. Yeah. So usually you feel about, 10 to 15 minutes, feel achy and back pain, joint feel, the hand feel a little bit swollen. And usually after like 15 minutes, it gets better. 30 minutes, it's gone. So those kind of joint stiffness, may not always be a rheumatoid disorder. For rheumatoid disorder, the morning stiffness usually lasts much longer. So the diagnosis criteria, it says more than 1 hour. So if in 1 hour, the morning stiffness just persists, then it's something that we need to think about. And some patients who have rheumatoid arthritis or lupus arthritis, they just say, oh, 30 minutes. So it's not like a written on stone. So some people can have a little bit less morning stiffness, and sometimes it's the patient's perception. Some patients are just so used to feeling stiff, and if they feel just a little less stiff, they think, oh, that's normal for them. Yeah, even though it's actually stiff. And they, after they get treatment, they say, oh my God, I did not know that what I was feeling was not normal. I thought that was normal. So sometimes it's the bias by patient's perception and their pain tolerance and their stiffness tolerance. Yeah, there's also some caveats there, but usually rheumatoid disorder patient will say that the stiffness lasts for longer and usually more than 1 hour. And also it'll come with some swelling issues. Not always. Rheumatoid arthritis not always can show the joint swelling that the patient can perceive themselves, but they can say something like, I cannot grab object firmly in the morning because I just feel my hand grip is weaker. And when their joints are swollen, they cannot make a full hand grip, the normal hand grip, and they can feel, oh, I cannot open a jar. I cannot do certain things that require the full joint function. So that's another one you can kind of, oh, maybe this is something more than hormone, and then maybe it could be actually autoimmune disorder. And also, if they have some other symptoms, such as have a rash that is photosensitive, so every time they go out, they get rashes on their cheeks. The lupus rash characteristically spare the nasolabial fold, so the line that connects the side of the nose to the side of the lips. If the rash really spares that line and comes on with the sun exposure, that can be suspicious for lupus. Or the patient can have some scaly rashes on their scalp or some abnormal nails. Nails look very, there's a lot of pitting in the nails. The nail just break down so easily. There could be psoriasis, or they could have some GI symptoms such as they have diarrhea all the time. They cannot gain weight because they just cannot absorb the nutrient. They see sometimes the flutters of blood in the stool. So they have some other symptom of autoimmunity. So that's a Crohn's disease or ulcerative colitis. So if they have those symptoms, those patients need to get evaluation to look for underlying rheumatologic or other autoimmune disorder. So that could be the giveaway sign for something else is going on.
Sure. So, another thing that I have heard is that rheumatoid arthritis, for example, affects joints in your hand, but if you have osteoarthritis, generally it's like these knuckles versus the metacarpals. So, which joints are more specific for the rheumatologic diseases versus osteoarthritis?
Yes, so rheumatoid arthritis usually involve these joints. So these joints called PIP joints and these knuckles, which is MCP joints. So those are the rheumatoid arthritis preferred joints to involve. Psoriatic arthritis can actually involve all of those. So psoriatic arthritis can involve the top joint, the DIP joint, the middle joint, PIP joint, and the knuckles, the MCP joint. So psoriatic arthritis can involve all of those. Osteoarthritis tend to more involve the top joints and the middle joints, but not the MCP joints. And osteoarthritis usually almost always at some point will involve this thumb base here because this joint, the thumb base joint, is the one that is most used in our hand because without this joint moving, we cannot actually do this opposition movement. So this joint is the reason why human can use tools.
You can't grip anything.
Exactly, yeah. And because this is the one that used the most people will have arthritis here, which will cause pain in the thumb base. sometimes this base can be protruded, and we call that thumb squaring. And when this one protruded, this one will just go in. So you may see some older patients, they have really protruded here and then look like this, almost like this. And that's one of the common signs. And bony prominence in the middle joints, which is called Bouchard nodes, and the bony prominence of the top joint, which causes Hebranden's nose. So those are sign of osteoarthritis. So one of the tips to differentiate this osteoarthritis and rheumatoid is when you just look at the patient hand, it could just look all swollen, but when you actually feel the joint, if it's mostly bony and just hard bone, it's most likely osteoarthritis. But in rheumatoid, it'll be softer and feels like almost like you're pushing a little mushroom. So that you feel some like soft tissue swelling or even some like fluid inside, and they will be more likely rheumatoid. Yeah. Osteoarthritis can also cause fluid as well, but it'll be less common than rheumatoid arthritis. And also, X-ray will look very different because osteoarthritis will cause more bone spurs, when rheumatoid arthritis will cause more bone erosions. So that's another thing that they can be differentiated.
Okay. So if somebody comes to you with joint pain and they are in that age, they're in their late 40s, and they say, oh, yeah, this joint pain started 2 years ago and it gets better, it gets worse, it gets better, it gets worse. How would you go about verifying that that person is actually having perimenopause related musculoskeletal pain versus a more serious condition?
That's a very good question. So that's the question that I wish there's a blood test who can kind of tell me just give me the answer, because it's very difficult to differentiate sometimes. And the first thing as a rheumatologist, what I would do is what I would do anyway to rule out rheumatoid arthritis or other autoimmune disorders. The history, associated symptoms, physical exam, blood test, X-rays, and those things, and that will give me about 80% of the answers, 80 to 90% of answers. This is likely rheumatologic or not. And if there's not enough clinical suspicion of rheumatic disorder, I usually don't push medication because it could be something else. And a lot of time it could be perimenopausal symptoms, or some patient it could be Hashimoto's disease. And when I check those TPO antibodies, the thyroid panels, or the patient other symptoms such as the person have hot flashes or not, so there will be some other symptoms that could signal that, oh, this person could have actually perimenopausal symptoms too.
So it's right back to the history again. It's right back to the history.
Yes, yeah, right back to the history. History is the most important. So if I have, kind of balancing, oh, is it rheumatologic problem or more perimenopausal or thyroid problem? If I have really little clinical evidence of rheumatic disorder and no blood test or X-ray findings, this score will just go down. And if there's a more of symptom of perimenopausal and there's no antibodies that signal autoimmune disorder, then it'll score will go up. I think it's almost impossible to have 0 and 100 scores. It's usually somewhere in the middle. One of the reason is rheumatic disorder actually does not have any single blood test to confirm. Even like a rheumatoid arthritis, 40% of RA patients actually don't have positive rheumatoid factor.
Oh my goodness. That makes it even harder.
A lot of RA patients will not have increased inflammatory markers in the blood, such as the SAD rate or CRP. And people can have severe synovitis in their joints, completely normal ESR-CRP, and no rheumatoid factor or anti-SSP antibody. So that's the reason why there's a no 100% score and 0 score, because there's no single diagnostic test like that. So it's more like a really clinical acuity about what kind of symptom the patient is going through, with some help of blood tests, but not completely rely on the blood test or the imaging. And then try the most likely treatment that will help the patient and we evaluate. But if the symptom and other evidence are less for rheumatoid disorder, using immunosuppressive agent for those patients will cause more harm than benefit. So obviously, we don't want to suppress somebody's immune system just because somebody have joint problem from menopause problem, right?
That's absolutely right. So I have a patient that I wanted to share with you because it's kind of just the opposite of what you just said. So the patient says to me, "You know what? I think I might have thyroid problems. I'm tired and my joints hurt when I wake up in the morning and I just feel terrible." And I asked her, I said, "Okay, when did you last have your period?" And she says, "Oh, about 10 months ago." And the reason she was seeing me is because her primary care doctor had said that she needed to go see a rheumatologist. He said, "I think you have lupus." And I'm like, "Well, do you have a rash?" And she's like, "No." And I did my very basic panel on her. She did not have thyroid disease. And I put her on menopausal hormones. And within 2 months, she was sleeping better. And her joint pain was 90% gone. And it was just like, I don't think you need to see a rheumatologist at this point. So, so yeah, it's so common. And it's funny to me that there are primary care doctors out there who jump immediately from joint pain to, oh, you have lupus when somebody is 49 years old. It's just a wild thing.
Lupus tend to be more active in the premenopausal women. So a patient who have lupus, I mean, it can occur to any patients, but lupus patients that tend to have most aggressive symptoms are usually in the premenopausal age, yeah, the childbearing age women, especially Hispanic Americans and African Americans. They can have severe nephritis problems, but it can come to any age. But it's something to think about because every woman will become postmenopausal at some point, and a lot of them will develop joint pain. But it does not mean that it's worrisome for lupus. Yeah, there's some other things, and osteoarthritis is a common thing, and that's what I have problem right now. Developing a Bouchard node in my right hand, so it's achy. When I wake up, yeah, it's normal. I'm getting older.
Yeah. Well, we're kind of coming to the end of our session, and there was one more question that I wanted to ask you, which was how has the COVID era changed your practice, specifically the practice of rheumatology in general? Have you noticed some changes there?
Yes, the COVID pandemic definitely 100% increased autoimmune disorders. It's somewhere about about 30% increase. I think the hazard ratio is about 1.3, according to the research. So definitely more patients develop autoimmune disorders after having COVID infection. Thankfully, not everybody who have COVID will develop autoimmune disorder, but it is clear that a lot of them can. And the positive ANA can be seen in about 30% of patients who have COVID infection. So if we test 10 patients who just have COVID, three of them will have positive ANA. Thankfully, not all of them develop disorder. I think about according to the one research, about 12% of those people can actually develop autoimmune disorder, most commonly rheumatoid arthritis or lupus or Sjogren syndrome.
Yeah, that's a really high percentage. That's really scary to me. Wow.
Yeah, and the researchers think that it could be because the COVID virus really disrupt the immune system and just cause systemic autoimmunity in the immune system. And this is not entirely new because we already know that EB virus infection can also increase autoimmune disorders.
Oh, Epstein-Barr virus. Yeah.
Yes, so there's these viral infections that really provoke the immune system. And the EB virus is actually the virus that infects the B cells, so that kind of makes sense. But COVID also tends to be really disruptive to the immune system and can cause autoimmune disorders. So definitely after COVID, I see a lot of patients who develop positive ANA, and some of them do develop rheumatoid disorders. I had patient very clear have time correlation with just 2 or 3 weeks after recovering from COVID, they just develop synovitis in the hands and that she never used to have before. So yeah, there's a definitely correlation between COVID infection and autoimmune disorders.
All right. So we are at the end of our time. So go ahead and tell the audience how we can find you, where to find you on the socials, and where's your office, and how can they work with you if they have an issue that they need help with?
So I practice in Murray, Utah. So it's a suburb from Salt Lake City, Utah. And my website is lotusrheumatology.com. And it's like a flower lotus, Lotus. I picked the name because lotus represent resilient beauty to me. And because lotus can thrive in the really murky water because it can purify itself. So when I think about patients who have autoimmune disorder, they are going through a lot of symptoms, joint pain, swelling, stiffness, fatigue, different rashes, and a lot of difficult symptoms. But with the right treatment and right lifestyle modification, they can still thrive in their life. And that's why I got inspiration from lotus flower because they bloom the magnificent flowers, even though they are stem from not the ideal environment. And that's the reason why I like the flower. Yeah, so it's lotusrheumatology.com. And I have YouTube channel and Facebook and Instagram, which can be found in the website.
Excellent. Well, thank you very much for coming on. This has been really fun and super informative. I learned a lot of things. And thank you for coming on the Beyond the Thyroid podcast. This has been really great.
Thank you so much for inviting me. It was such a fun talking with you.
Yeah, I enjoyed it. All right. Bye bye, everybody. Thank you for listening to this episode of Beyond the Thyroid. If you found this information valuable, it would mean so much to me if you'll take a few seconds and give the podcast a 5-star review. It helps other people who need this information find the show, and it's really easy. Just search and click on the name of the show, Beyond the Thyroid, and scroll to the bottom to ratings and reviews. I truly do read and appreciate every one. Remember, when it comes to hormones, there will always be more to discover. So follow the show so you get the next episode as soon as it's released. And if you or someone you care about needs a caring doctor to help figure out how to heal hormone problems that other doctors have dismissed, check out my website at www.danagibbsmd.com. And if you're not a physician, please keep in mind, while I'm a doctor, I'm not your doctor. The content of this podcast is my opinion, and it's for educational and entertainment purposes only. This is not meant to be individual medical advice, and you should consult your own physician for any medical issues or diagnoses that you may have. I look forward to continuing this journey with you beyond the thyroid.